Hi all, thanks for joining, and welcome to the day one panel discussion of AETLS 2021. And as you all know, the topic for discussion today is nutrition in ICU. And as we have already told you, those who have any doubts, any queries regarding the initial two talks can put in your queries as a comment in this session. And we have, as we usually do, we have already have few pre-planned questions, and after that we will be taking your questions. Right. So for this discussion, we have a very expert panel of doctors with us. To introduce them, Dr. Ashwin, who is a consultant in the Department of Neonatology. Welcome, Ashwin. Next is Dr. Sajid. He's head of Pediatric Pulmonology and Critical Care at Amrita Institute. Welcome, Dr. Sajid. And Dr. Shyam Sundar sir. He is an intensivist and additional professor in the Department of Anesthesiology and Critical Care. Welcome, sir. So this is how we have planned. We will be having a general question, which our experts will be sharing their own perspectives from their specific age groups. That's how we have planned. So the format is we will start off with an opening statement, close to 3 to 5 minutes, on the importance of nutrition in ICU in their specific age groups. To start with, Dr. Ashwin.
Hello all. Neonatal nutrition perhaps lays the foundation to anybody's or an adult's life or healthy lifestyle. So when a baby is actually born, if the baby is stable, most often babies on breastfeeds, which is kind of the ideal feeds a baby can get. Mm-hmm. But most often what happens when a baby is sick, especially preterm babies with breathing difficulty, respiratory distress, they are in the ICU, and then most often we are not able to feed them adequate breast milk. Sometimes we don't even feed them because they are hemodynamically unstable to feed. So most often they are on parenteral nutrition. Okay. Sometimes we start transitional nutrition where partly they are on feeds and partly on TPN, and then we try to achieve very high calories and protein in the NICU. Okay. But when a baby is born extremely preterm, mm-hmm. what we generally see is that we are never able to catch up with the growth which the baby has in utero. So the fetal growth, we are never able to catch up. Okay. So when a baby is born at say 25, 26 weeks, what happens is they have a weight which is appropriate for that gestation. Mm-hmm. Mm-hmm. But whilst the baby is in the NICU and during the stay, baby might be with us for close to 10 to 12 weeks. By the time the baby goes home, what we see is the baby is actually much below the 10th centile for that gestation. Okay. So that's like 50% of what the baby should have been if the baby was actually growing in utero. Okay. So that's kind of a significant actually deficit in the protein and calorie and fat in the baby, and even micronutrient deficiencies. There are so many studies, even our own study which was published a couple of months back, what we have seen is if the baby does not grow well in the NICU, mm-hmm. or again later on in life the baby does not grow in the first few weeks in life, what happens is later on by around 2 to 2.5 years of life, they have significant neurodevelopmental issue. Okay. They have motor deficits, they have psychomotor deficits. So various scales have been used to identify this, and then what we have found is they have significant delay in development when they are not fed. That is irrespective of the disease stage the baby had in the NICU. Okay. So there is always an effort, and that's something which always all NICU should attempt, is to provide adequate nutrition, try and achieve at least 100 to 120 kilocalories and good amount of protein to avoid negative nitrogen balance and catabolism in the NICU. I think that goes a long way.
Yeah, I think that sets the tone for the discussion, and we will be coming into the details as we move on. Next to Dr. Sajid, from a pediatric perspective, if you can.
So, pediatric perspective in the PICU, nutrition is very important, as there has been several retrospective studies which have linked undernutrition at admission, as well as lack of failure to attain target prescribed goals of nutrition in the ICU, mm-hmm. to be directly linked to outcomes, okay. especially the length of stay and mortality. So there is no doubt that they're linked. Mm-hmm. Unfortunately, what is the main challenge in pediatrics is unlike in adult critical care, there is lack of randomized control trials and high quality evidence which guides us in nutritional prescriptions. Okay. So what we are left with is some formulas and equations which we use, as well as some institutional guidelines which are followed around the world. And 2017, we had the first guidelines combined with the AETCM and ASPEN on pediatric nutrition in the ICU. Following that, in 2020, we also have the European Society of Neonatal and Pediatric Intensive Care guidelines on nutrition in ICU. So these two remain the main guidelines on the basis of which we currently prescribe nutrition and follow up babies. So there is the need of the hour is to have more pediatric oriented studies and ways to target nutrition. So most of the evidence is extrapolated from the adult, plus some institutional practice is what guides us right now.
Okay. Coming to Shyam sir, if you can throw some light on the topic from an adult critical care perspective.
I mean, nutrition is not just a supplement as we understand nowadays, and it's more to do with, the recovery from the disease itself is not just on the treatment that we give. It's also based on nutritional support that we provide period of the acute phase. Following which they can either recover to normalcy while they go in for rehabilitation, or they could go on to a chronic inflammatory state. And the importance of nutrition comes in here. If the nutrition is not adequate, not proper, not given the right way, it could lead on to a chronic inflammatory phase. So that's the importance of nutrition. And the other importance of nutrition, especially enteral nutrition, is, as we all know, is to preserve the intestinal integrity of the epithelium, maintain the tight junction, thus preventing translocation of bacteria that we all know. But more important, nutrition, enteral nutrition especially, is also important for release of the brush border enzymes, as well as maintain immunity, which we have learned, especially with the COVID pandemic over the last year and a half, how important it is, nutrition is in the maintenance or improvement of immunity. So these are the things that is important when it comes to nutrition. It should not be seen as a addition to the treatment. It should be part of the therapy.
Okay. Thank you, sir. Moving on to the next question, I'll start again with Ashwin. Ashwin, who are at risk of developing malnutrition from a neonatal perspective? Yeah.
Obviously, any baby, or from the NICU standpoint, any baby who stays in the NICU for longer than a week actually is at risk of developing malnutrition. But the babies who are really at high risk are the ones who are born extremely preterm, because most of them cannot be fed. Some babies who are fed do not necessarily tolerate the feeds. They have a lot of gastric residues, and they can develop abdominal distension, various complications related to feeding because the gut is very immature. So feeding may not be an option at that point. So we are left with TPN. TPN, again, we may not be able to provide the adequate calorie, protein and fat which the baby actually needs. So preterm babies are the ones I would say are at the they are the highest risk of developing malnutrition in the NICU. So we call them when they actually don't grow in the NICU, we call them extrauterine growth restriction. We all know about intrauterine growth restriction, where they don't grow in utero, but when they are actually not given adequate nutrition, we call them extrauterine. Other problems would be babies who actually have a bowel surgery, short bowel syndrome, babies who develop chronic lung disease because of ventilation and infections and all that. Chronic lung disease, actually they require very high calories for growth. Sometimes steroid therapy, babies who are on steroids, again they don't necessarily grow well in the NICU. But I would still go back and say preterm babies are the ones who really struggle in the NICU.
So it's anything from your end?
From a pediatric ICU point of view, I'm sure it's the same in adult as well. Across all diagnoses, the patients who are at the highest risk would be Burns patient. Burns patient, there is literature showing that their catabolic response and their hypermetabolism can last for up to 1 year after Burns. So across all patients that is admitted into ICU, Burns patient would be the most severe, the patients who are at highest risk of, especially significant burns, not mild burns. The second group will be children who have pre-existing undernutrition. So at the time of admission itself, have anthropometric parameters which suggest that they are at risk of malnutrition. So they are not only they are pre-existing malnutrition, but they have more risk of ongoing malnutrition while in the ICU. The third group would be surgical patients, especially patients who have had abdominal surgery and those kind of patients. They are also at risk because whenever we face a challenge in not being able to provide enteral nutrition, it is very, very difficult to provide prolonged parenteral nutrition in a setting like ours where infections and other complications related to central line are very prevalent. So if we have a functioning gut, then we are very happy. If we don't, then it's a challenge.
I think the burns part we can extrapolate into the adult also. Anything else, sir?
Like Dr. Sajid mentioned earlier, we fall upon two main guidelines when it comes to nutrition. One is the American Society, the other one is the European Society. The American Society last came up with their guidelines in 2016, whereas the Europeans updated it in 2020 after their last one, which was in 2009.
Okay.
There is a slight disagreement between the two guidelines, and since the European one is latest, we'll have to go by that. And as per the ESPEN guidelines, what they've said is that any patient who is likely to be in ICU for more than 48 hours is at risk for malnutrition. So that's the current, so that's how they want us to take any patient. But all the subgroups mentioned for the pediatric age would apply here as well. So probably we need to start monitoring them a little earlier, but then any patient who's likely to be there for more than 48 is at risk of malnutrition. So we'll have to take care.
So irrespective of the diagnosis, this would stand good. Yeah.
Absolutely.
Yeah, fine. So next question I will start with, sir. Sir, how will you evaluate the need for a nutritional support? There are certain scores, there are various other methods being propagated. So what's your take on it?
Okay, I can't certainly have a take on this because the two big societies themselves over the last decade and a half have failed to come to a proper consensus regarding how to go about assessing the nutritional status. Like you mentioned very rightly, there are various scores. The Nutrix score is what we are very familiar with because that's what the ASPEN guidelines along with the SSC seem to be advocated in 2016. But unfortunately, the ASPEN group has disagreed with that and they don't agree to Nutrix score at all. And they do suggest some of the other scores. So the three different scores that they are including is one is called the subjective global assessment, which includes history and a lot of physical examination. I can't go into the details of all that. And then we have what is called the mini nutrition assessment, shortened form of that, which is advocated by the European group, as well as another one would be the NRS 2002. So, but then again, they couldn't come to a conclusion regarding which is which. The MNA short form has got the highest specificity, whereas the NRS 2002 has the highest sensitivity, but they consider the subjective global assessment as the gold standard. But again, they do not say that you should follow one of this because they are saying the studies are yet to come. We need more studies to pinpoint on one and so in the meanwhile, what they have suggested is to go for a pragmatic approach, which would include, physical examination and history, and in which they say you look for any weight loss in the last 6 months. Someone has had weight loss in the last 6 months. They've had a period of, where they've not had an oral intake for whatever be the reason, and all such things. So just go by clinical evaluation, a little bit from the history, go look at the BMI, and you could do a little bit of, what we can say, assessment of body fat, like your arm circumference or something. You can include all that. So institutions will have to develop their own method. The societies do not prescribe one current scoring at present, though there are a few, and you could follow any of those, but they're not saying that you should follow.
On to Dr. Sajid, what do you follow in your ICU for evaluation of nutritional status?
So this Nutrix score has not been validated or is not suitable for children. So what for children in ICU, we don't have a score. So we use the pragmatic approach of history, underlying diagnosis, as well as anthropometry. In anthropometry, the most important anthropometric measures that we use in kids are BMI Z scores and your mid-arm circumference and tricep skin fold thickness. These are the three things that we use it in the as anthropometry. In terms of scores, there has been scores which are used for hospitalized children, but not for critical illness or based on their diagnosis. Okay. One score which is used in, which is developed in Belgium is called Strong Kids. Okay. It's not suitable for, not tailor-made for ICU, but more for hospitalized children. So, and even there, it was mainly used for a study purpose. Like if when you're doing a study of nutrition, there you need an objective score to find out patients at risk. But for all practical purposes, none of these scores have found routine use in ICU practice. We use mainly anthropometry and history.
Okay. Ashwin, anything from neonatology?
Obviously, there are no major scores or anything that we use. Yeah. But bottom line is all babies will require adequate nutritional supplements. To maintain the normal basal metabolic rate, they need at least 50 to 60 kilocalories per kg per day. So you will definitely have to give more calories than that to maintain some kind of to avoid negative nitrogen balance, protein breakdown, and then actually build on the baby's actually growth. So adequate storage of fat and all that. So basically you will need at least 70 to 80 kilocalories per kg per day to have at least a normal kind of at least avoid weight loss. But to have a significant weight gain, we'll need at least 120 kilocalories per kg per day. So we check the baby's weight every day in the ICU, and then we need at least 1% weight gain per day. In grams. So, and then we average it for a week. Obviously, preterm babies, we check the head size and length and all that, and then we plot on various preterm charts and see how the baby is growing and whether it is actually comparable to the fetal growth. So we don't have specific scores, but all babies will require adequate nutrition. There is no doubt.
Okay.
Just to add on to that, the weight part of it, we might tend to think that someone who's obese is healthy and at least nutritionally, but we need to understand that obese individuals can be malnourished as well. Okay. So when it comes to BMI, anyone, still again, we'll need for races. So if we go by the American standards or the European standards, for Asian standards, we may not meet there. So there's one thing there. If a BMI is less than 20, currently the Western population would consider that as malnutrition, but for Asian population, it's slightly less at 18.5. So that is for sure. But at the same time, we need to understand that patients who are obese could also be malnourished. Okay.
Right. So another thing which we often come across when we read about literature is about the role of indirect calorimetry. If Dr. Sajid can share some insights on it.
So the main reason why indirect calorimetry is useful is because of the lack of accuracy for all these predictive equations based on which we prescribe nutrition. Like we can use the Schofield formula, the Harris-Benedict formula, a lot of formulas are there, but all the studies have consistently shown in children that none of these are good. They do both ways. They overestimate as well as underestimate the needs. So in a patient who is not doing well nutritionally on follow-up, indirect calorimetry would be very useful, not only to prevent underfeeding, but also to prevent overfeeding. In fact, overfeeding is something that is more important because everybody thought that in critical illness, it is hypercatabolic, then you need to give them more calories. But there has been a shift in thinking and evidence suggests that most of these patients use 40 to 60 calories per kg per day. Okay. And they don't use the full 100% in at least in the first few days. So to objectively measure, previously we used to use the direct calorimetry, but it's very difficult in ICU where actually you measure the heat that comes out of burning fuels. So the surrogate for that is by measuring the volume of carbon dioxide produced per minute and the volume of oxygen which goes in. So that is a surrogate. That's called the respiratory exchange ratio, which is the VCO2 by VO2. So if you have in a patient who is intubated, who doesn't have a leak around the endotracheal tube and who is not on very high oxygen, the indirect calorimetry is a cart which can come to the bedside of the patient and it's an add-on to the endotracheal tube where you measure the volume of carbon dioxide produced and the volume of oxygen which is going in. And then using an equation called the Ware equation, you can calculate the resting energy expenditure. So most of these patients who are critically ill and who are ventilated, you just need to give them the resting energy expenditure. You don't need to give them the growth and other things in acute illness. So if in a center, like there are centers in the world, pediatric ICUs like Boston Children's, Sick Kids, where they use indirect calorimetry at the bedside for adjusting the diet. But I'm not aware of any center in India in the PICU which is using this indirect calorimetry, because they are actually expensive tools. In a center which does research on them, they find it more useful to actually measure. And all the research indicates that it is needed for a specific group of patients who are at very high risk of underfeeding as well as overfeeding.
Okay, so the limiting factor there is going to be the expenses involved.
Yeah. It's an expensive machine, and it is not that easy to do at the bedside, because you cannot do it on a patient who is needing very high oxygen, and you cannot do it if you have a significant leak around the endotracheal tube.
Shamsad? No.
I mean, indirect calorimetry is actually, though it is being recommended now, a lot of it's a long way before we could be doing it, but by the time we get up to there, we might have other methods. But currently what is available is the newer ventilators, at least they give us VCO2. And VO2 can also be calculated from our hemodynamic monitoring. We can simple non-invasive. If you have an arterial line, you have this hemodynamic monitors which will give you the VO2, and the ventilators do give you the VCO2. So if we can have a formula fed into it, it can become easy. So this is being simplified with just the newer ventilators and hemodynamic monitors which give you VO2, and so you could do this as well. So it's not as difficult as it is, but we have not formulated methods, especially not in our institute yet, nowhere in India, like Dr. Sajid mentioned, but it can be done. It's not the actual indirect calorimetry, but we could get a surrogate of that itself, in a way.
Okay. Next question, I'll again move to Dr. Ashwin. Ashwin, what's the recommended daily energy targets? You have already just hinted on it, but if you can just elaborate once more.
Yeah, so basically, like I mentioned, the resting energy expenditure the baby has is around 50 to 60 kilocalories. So definitely you will need more calories and protein than that.
50 to 60 kilocalories
per kg per day.
Yeah.
So definitely we would need more calories.
Yeah.
But that's the target on the first few days of life. So maybe maybe 3 or 4 days we would target around 50 to 60, or maybe sometimes if we are lucky, maybe around 70 to 80 if we can achieve that.
Okay.
Target protein, there are various guidelines, but the NICE guidelines, the UK guidelines say start at 1 to 1.5 grams and then slowly build it up to 3 grams.
Okay.
But there are various studies which say that babies can easily tolerate up to 3 to 3.5 grams on day 1 itself without seeing any toxicity related to high amino acid intake.
Okay.
So that will be the initial few days, that will be the target. But later on, once the baby is on feeds or TPN, we would like to target at least 120 to 130 kilocalories per kg per day of total calories, and out of that, protein should be around 3 to 3.5 gram per kg per day.
Okay.
This is again extrapolated from the fetal lamb models.
Okay.
So if you look at the fetal lamb models, the amount of protein which the fetal lamb actually gets is around 3.5 to 4 grams. So we give somewhere close to 3 to 3.5 grams, and some studies even recommend 4 grams protein per kg per day.
Okay.
But when you give the adequate calories, it should be always split up into various proportions. In the sense, the carbohydrate should not exceed more than 50 to 55% of the total calories. Fat should be 30 to 35% of the total calories, and protein should be 10 to 15% of the total calories.
Okay.
So that proportion also has to be maintained.
Okay.
You cannot keep giving more carbohydrates and very less amount of fat, which is again not very healthy. Okay. So that proportion has to be maintained, but the total target calories to attain adequate growth would be 120 to 130 kilocalories per kg per day.
So what do you usually give? It's all commercial preparations, or?
Yeah, in India at least for now, there are no TPN preparations which are commercially available. So we prepare our own TPN formula. We have a laminar flow where we prepare our own TPN. We calculate the the carbohydrates or the sugar based on the GIR, that is a glucose infusion rate.
Okay.
The glucose infusion rate, generally we try and keep it around 6 to 8 mg per kg per minute. That's the GIR. That's again extrapolated from the endogenous GIR which the liver produces. That's around 4 to 6. So you want to give slightly more than that.
Okay.
And then based on the protein, again, we generally start at 3 to 3.5 grams in RNICU.
Okay.
Fat, again, we don't start immediately, but once the baby is stable, there's no evidence of sepsis, infection and all that, and then we started. But again, the major limiting factor being the cost of lipids is more. But you definitely would need lipids on board for the baby to achieve that 120 to 130 kilocalories, which I was talking about.
Okay.
Without lipids, you never achieve that value.
Okay.
So we prepare our own formula and then the fluids based on that.
Fine. To Dr. Sajid, the same question.
Yeah. So, I mean, if you were to ask any pediatrician what is the calorie requirement for a child, they would give you the holiday cigar formula for each first 10 kilo, 100 calories per kilo, and then 50 and then 20 and so on. But these are for normal children who are not for critically ill patients. So if you prescribe according to holiday cigar, it will lead to overfeeding. And data uniformly says that in critical illness, you don't need that much. Okay. So at least in the first week, or I mean, some patients might be in that period for a few days. Some patients maybe for a week. They are not uniform. All of them are not uniform. So unless it's a burns patient. So burns patients are different because burns patient, from day one, they go into hypercatabolism. You need to give them a lot of calories. Yeah. We hardly ever exceed 40 to 60 calorie per kg per day for any patient. So we don't go up to 100 and all for that phase. But when they are growing, some of the patients spend a long time in the ICU, like especially currently in our ICU, we have 3 patients who have been in the ICU for more than 3 to 4 months. But in those cases, we might have to change the strategy and prescribe according to their growth. Okay. So we can start off with 40 to 60 calories per kg as a starting point. Okay. And then based on anthropometric measurements and other markers during their stay, we would adjust their caloric intake to slowly grow up to the holiday cigar levels, because holiday cigar levels is too high for critical illness.
Okay. Fine. Sham sir?
Yeah, so in medicine we would have heard of the term that kids are not miniature adults. So by now you would have known that they are not, because it's different. And when I say the adult values, you'll know that they are altogether totally different. So you started off at somewhere 100 kilocalories. Yeah. That's like looking like Himalayas to me, because adults need anywhere between 20 to 30 kilocalories per
so we started
kg.
with 100 to 60 to the other way around.
Yeah, so 20 to 30. So I would, we normally prescribe at 25 kilocalories per kg per day.
Okay.
Of non-protein calories. So we don't include proteins in that. And are we discussing proteins?
Yeah, we can go along with this. Yeah.
Okay, yeah. So proteins is, it used to be 1 to 1.5, but then the European Society has come with a very fixed value, single value of 1.3 grams per kg per day. So that they're very specific with that value. So I would.
That's going to stand good for all diagnosis, or maybe renal, everything is
all diagnosis, including renal, everything. And regarding the proportion of calories between carbohydrates and fat in adults, unfortunately, we don't have a proportion, but there's an upper limit, or for the fat that is like 5 grams. But for carbohydrates, there's nothing. So you can decide on the proportion for yourself. Okay. But the calories would stay at around 25 kilocalories per kg per day. Protein at 1.3 gram per kg per day.
Okay, fair enough.
I'll just add the protein for children. It is 1.5. Okay. So our guidelines say 1.5 gram per kg per day. So there again, 3 grams to 1.5 to 1.3.
Okay. So one more thing, Ashwin, regarding nutrition, we often miss about electrolytes and minerals. So I think that's something which is very important, specifically in your age.
Yeah, that's very important, especially when a baby is born preterm. Again, most of the mineral transfer from the mother to fetus actually happens in the 3rd trimester. So when the baby is actually born preterm, the baby especially born less than 28 weeks, there's significant calcium, phosphorus and other mineral deficit. So if we don't aggressively challenge them with adequate calcium, phosphorus, vitamin D and all that, they significantly go into something called as osteopenia of prematurity.
Okay.
So if you see the previous X-rays, maybe 20 or 30 years before, actually babies who are on ventilator sometimes can actually develop spontaneous rib fractures. We don't see that nowadays because we aggressively give them adequate calcium, phosphorus, vitamin D, and all that. In addition to that, we also give electrolytes.
Okay.
Sodium is very essential. Again, preterm babies, they can lose a lot of sodium in the urine. So if you don't give adequate sodium, it again indirectly affects the bone mineral density. So sodium again is very important. So we give them, so first 24 hours we generally don't give them other than minerals other than calcium. After that, from 24 hours, we give them sodium, potassium based on the clinical condition of the baby and the gestation and all that. So they definitely need that. And then again, we also check their levels like the calcium, phosphorus, vitamin D levels and all that whilst they are in the NICU. That again, the monitoring is very essential.
Okay. Said, sir.
So regarding electrolytes, one of the key electrolyte in ICU is sodium, and a lot of ICU patients, I don't know about adults, but children are very prone for hyponatremia, and the reason is giving them hypotonic fluids. This is again a change from the neonatal practice where they give a particular millimoles per kilo per day of sodium. But in PICU, usually the sodium is prescribed, making sure that you don't give them hypotonic fluids. So even if it is a 6-month-old or a 1-year-old or a 2-year-old, you start by giving them 0.9 or isotonic fluids or ringer lactate or plasmalite or something. But if somebody is having hypernatremia or hyperchloremia, then you change to half normal saline or half whatever. In terms of minerals, other minerals, if somebody is on TPN, there is standard guidelines on how much minerals you have to give them in terms of calcium, phosphorus, and all of that. And even though there are no specific ready-made TPN prescription for neonates, because but we can sometimes use the adult 2-in-1 or 3-in-1 TPN preparations which adults use. Sometimes you might have to waste a lot because of the hanging period and all of that. But some of our patients, we are able to get away with standard TPN prescription, so we don't have to worry too much about individual.
That is beyond which age cutoff? Or?
It depends on how much we can waste, because once you mix something, then it can only stay for a particular period of time. So if it is a very small baby, obviously you'll be wasting a lot of this ready-made TPN. So if they are bigger age and if we can run it over 2 days, then we might be able to get away with using ready-made TPN prescriptions. Otherwise, we'll have to go for TPN, homemade TPN inside the ICU. We don't have a laminar flow, so we'll have to use the hospital pharmacy to get that TPN.
Okay. Sham sir, regarding minerals and electrolytes.
Electrolytes, the normal requirement per day, they don't specify any difference from the normal requirement of electrolytes. But regarding monitoring of electrolytes, it's very important that we start monitoring them from day 1 onwards. What is suggested is to monitor, sodium, of course, potassium, magnesium, and phosphate on a daily basis, at least for the first 3-4 days. Because if the patient especially has had a period of, where there's been a decreased intake prior to ICU admission, and during the first 2 days when we are not that aggressive in giving them the nutrition, and then after that when you start feeding them, if there is any risk of a refeeding syndrome developing, that your clues are going to be from your electrolytes. So if you have significant hypoelectrolytemia like hypopotassium, hypokalemia, and low potassium and low phosphate and all that, what is recommended is to just hold on to your nutritional supplementation, the calories, not stop it, but reduce the amount of calories that you would give, and then slowly after correction of the electrolytes rebuild on your calories. So in the initial few days you are supposed to monitor on a daily basis electrolytes.
Since you mentioned about the refeeding syndrome, if you can just put some thoughts on that. What is refeeding syndrome and how we
Okay, the
recognize it?
refeeding syndrome is not something that's commonly seen nowadays.
Okay.
Like earlier, we used to see a lot because they would be on longer period of, food. I mean, food would be, I mean, in intake would be restricted and all that.
Yeah.
But now with this policy and guidelines where we are going for early enteral nutrition,
Yes, sir.
within the first 48 hours of ICU stay, if they're going to be in ICU for beyond 48 hours, we would start feeding them. So we don't quite see the refeeding syndrome, but if there has been a period of no food intake, and if you start feeding enterally or even orally, you could see refeeding syndrome happening, where there is significant hypoelectrolytemia is the main identification point. So you need to look for phosphates, potassium, and magnesium. So if they are low, like I said, just hold on to the amount of calories you would give. Don't start them at 100% of the calorie target, which we said earlier, 25.
Yeah.
So we would go to around 70% of that is adequate in the first 3 to 5 days. Then build up onto that by 5 to 7 days. You come to 100% of the calorie target. You're not going to see this refeeding syndrome at all. So we don't see it, I would say, in the adult ICU nowadays. Very rarely only to see.
Okay. I again request the audience to put in their questions. We'll be taking it at the end of the session. So moving on, I think there's a general consensus that whenever we can use enteral nutrition, that is kind of the choice, irrespective of the age group. So coming on to a few specific things about the enteral nutrition, again, I will start with Sham sir. I club two questions. One is regarding continuous feed versus intermittent feeds, and NG feed, that is nasogastric versus nasojejunal feeds. So if you can just compare.
Quickly I'll answer both. Coming to continuous feed or intermittent feed, what is recommended is continuous feed in the adults. So enteral feeding I'm talking about, continuous enteral feeding via nasogastric, nasojejunal, I'll come to that. But a continuous feeding is what is recommended. Okay. What we practice is we give it continuously for 18 hours, the total calories that is required. So we start at 6 in the morning, goes on till 12 in the midnight, and then we give a 6-hour break from 12 in the midnight to 6 in the morning. And subsequently we start it. So, and this is what is recommended. It's not like it's recommended for 18 hours, but continuous feeding is what is recommended. There are units which just keep continuing all the 24 hours. So continuous feeding is what is recommended currently. Coming to the second question, whether it should be a nasogastric feeding or nasojejunal or post-pyloric feeding. Gastric feeding is what is routinely recommended. So nasogastric feeding is fine. Then the question comes is, if they don't tolerate, then what do we do? So they don't prescribe nasojejunal or post-pyloric feeding immediately. They do ask us to try giving prokinetics. What is recommended currently is erythromycin, intravenous erythromycin. The second choice would be intravenous metoclopramide. So they ask us to try either intravenous erythromycin or intravenous metoclopramide, or a combination of both if the patient is not tolerating. Only then do they suggest trying post-pyloric feeding, and when it is post-pyloric, it's predominantly nasojejunal feeding is what is recommended. So you'll have to place the nasojejunal tube with some sort of guidance. You can't blindly do it. Some sort of endoscopic or a fluoroscopic guidance. You'll have to place a nasojejunal tube. Only if they don't tolerate nasogastric, and if you've tried out all other measures like giving prokinetics as well. So otherwise, it's nasogastric, continuous feeding.
Dr. Sajid?
So the key question is not what is better. The key question is do you have a structured and protocolized approach is the question. So whether you do, so there is no evidence which favors continuous over intermittent. There's nothing which favors intermittent over continuous. There's nothing which favors post-pyloric versus gastric. So the evidence is that you should have a written standardized approach to how you feed critically ill patients. So there are excellent institutions in the world which follow routine continuous feeds. There are centers which follow bolus feeds. So both of them have got the same kind of results and the same kind of feed intolerance, everything. But in somebody who is at risk of aspiration, or somebody where you are not sure whether they will tolerate feeds, usually continuous is preferred over intermittent to start with. In terms of post-pyloric, again, it is not chosen as the first choice in any place. It is usually only chosen when somebody is not tolerating gastric feeds. And it is quite challenging to insert post-pyloric tubes at the bedside. So there are some centers which have created protocols where some senior nurses are trained to place this blind at the bedside, and they report between 50 to 80% success in bedside placement.
Okay.
And there are some centers which shift them to fluoroscopy and place them under fluoroscopic guidance. We have also had some success in placing them under fluoroscopy, but the bedside placement success for post-pyloric is actually pretty low in our ICU.
Okay, so you use the conventional Riles tube or the Fricas or?
So the Fricas tube, the minimum size is 12. Okay. So we are limited by the age. So we cannot use Fricas until they're 2 years old.
Okay.
So we are forced to use the conventional Riles tube for putting them, and that is probably why our success rate is low. I think if you use the Frica tube with the guide wire under fluoroscopic, we have placed 2 or 3 in our ICU under fluoroscopy, the Frica ones. Yeah. The Frica ones have had better success than the conventional tubes.
Okay, okay. Ashwin, does it matter in
Yeah, I think this is one topic I think we all agree for a change. But like what Dr. Sajid said, actually continuous versus bolus, you choose for continuous only when there's significant reflux.
Okay.
When you feed the baby, and actually there's a lot of reflection which is causing frequent apneas and choking and all that. That's one situation where we choose continuous feeds. Other situation would be when the gastric emptying is significantly delayed. Okay. So you cannot feed bolus, and then there's a lot of reflex, or there's pre-feed aspirates and all that. So in those situations we choose continuous, but most often we give bolus feeds. Actually, there are various studies in neonates. Recent one in 2019 where it was a meta-analysis where they found that bolus feeds were better, okay, but not to a great extent. What they found was these babies actually reached full feeds earlier than continuous feeds. Rest of the parameters in terms of growth, their development, everything were similar. Yeah. One situation which is kind of different in neonates, where we specifically use post-pyrovaginal feeds and then transition slowly to nasogastric. Okay. But bolus feeds are always preferred than continuous feeds. Okay. They actually, it improves the insulin release, and also amino acid metabolism is found to be much better than continuous feeds.
Okay, fine. Sham sir, next question. Something which we usually follow in ICU is to look for the gastric residual volumes. So, but how often should we be doing it, and how to interpret how to feed based upon the volume which is residual?
Okay, yeah, gastric residual volumes is again one topic which has gone to and fro, whether you should measure, not to measure, but there was one point of time when we were giving for 1 hour and aspirating the next hour, and then some people said you have to reintroduce it, and so there's a lot of confusion. Yeah, if the gastric residual volume which you measure by aspirating and checking, if it's more than 500 ml, it is taken as intolerance to gastric feeding. But it's not recommended shorter intervals, you don't have to check for it. Mm-hmm. If at all you have a protocol to check, it should only be at 6-hour interval. Mm-hmm. So that's what we do. What we tend to do is we give them a 6-hour break, and then check it at early morning. If it's 500 ml, more than 500 ml, probably we would not withhold the enteral feeding totally, but we'll reduce the volume that we give. Maybe a couple of for days we would give a smaller volume, add them onto the kinetics, and as things improve we would build up on the volume. So if you want to check it, it is more than 500 ml on a 6-hour basis is what is considered as intolerance to feeding.
So the frequency of checking is 6 hours.
6 hours and 400, which we do not follow routinely. It's not recommended as well. But if you want to check it, it has to be done 6 hourly, and more than 500 ml in an adult is considered into. Any volume less than 500 is considered as normal.
Okay.
So, in children, the European guidelines recommend not to do it based on a study where they compared 2 centers, one in France. In France, they do gastric residual volume. They don't do gastric residual volume, and in UK they do gastric residual volume. So they selected 2 identical centers. I think it was Liverpool and Lyon in France, where they looked at their ability to reach full feeds and all the factors, and they found it to be no different. So based on that, they felt that this routine measurement of GRV is not needed. Okay. But I think the role of GRV is when you start feeds and build up feeds. Okay. So initially, because it gives you an objective measure of whether somebody is tolerating or not. And like Sir mentioned, 500 ml in children, it is 3 to 5 ml per kilo.
Okay.
So starting of feeds is 1 ml per kilo per hour continuous feeds. This is the so I was reading the Boston Children's feeding protocol, and their policy is if somebody is ready for enteral feeds, they place an nasogastric tube and they start feeds at 1 ml per kg per hour.
Okay.
And after 4 hours, they measure the gastric residual volume. If it is more than 3 ml per kilo, then they put it back. And then they leave for 4 hours and then start again.
Okay.
But if it is, and again, they will again keep trying it again and again. So the numbers to remember: 6 hourly, this is 4 hourly, and there 500, this is 3 to 5 mils per kilo.
Okay. Ashwin?
Again, gastric residuals is again very, very common in neonates, especially preterm neonates. They don't tolerate feed, so you give few ml of milk and then you may actually get that same milk back. But the number actually when we get worried is if it is more than 50% of the feed volume. Suppose you give say 20 ml and then you get 10 ml back. That's when we really get worried. But you cannot use that number for all situations. Suppose you give only 2 ml and then you get 1 ml back. We're not worried about it. But if it's a large volume that you're giving, say the baby is almost on 50% feeds, and out of that 50% comes back, then you really get worried.
Okay.
Other than that, it's very, very common, and then we just move on. We just give that the aspirates back and then wait.
Okay.
Sometimes skip a that's very common in neonates.
Right. Next thing is regarding TPN, but I think we have already had a detailed session on TPN in an adult perspective, and Ashwin also mentioned about TPN in his talk. So I'll just limit it with the pediatric perspective from Dr. Sajid. Where do you use TPN and how successful do you
So luckily there we have a pediatric trial. So there was a trial in 2016 called the PEPANIC trial, which is 4 centers in Belgium where they compared early TPN versus delayed TPN after 7 days. And across the subgroups, including the subgroups who had previous malnutrition, they found that early TPN is harmful. So right now the consensus is that any patient who is coming into ICU, you assess whether you will be able to achieve at least 50% of a target goal of enteral nutrition within a week.
Okay.
If you think they are unable to achieve then you can start. Okay. Even then you kind of wait before starting on the first 24 hours. If the expected duration of NPO and is more than 7 days, you can start TPN.
Okay, perfect. So I'll move on to the last question in view of the time constraints. Sham sir, another specific group where nutrition might play a major role will be the post-operative patients. So is there anything specific we need to look into it, or when to start, especially with GI surgeries and things like that?
So I'll just talk on GS surgery perspective, because all other surgeries, I think they would be started on oral feeding, not just enteral feeding. So GI surgical patients, especially most of the patients who have some sort of anastomosis or anything, upper GI anastomosis and all, what they do is they place a feeding tube distal to that, a feeding jejunostomy or something like that. So if that is in place, then we are going to start enteral feeding within the first 24 or at least by the first 48-hour period. We would have started, but it's going to be small volume, something like 25 ml per hour of small, and we don't start feeds per se. It might be just clear liquids. We start them on that, and if they tolerate them for 24, 48 hours, we increase the volume and then we move on to feed. So especially if we can feed them by day 5 or so and reach that 70% target by day 7, they are fine with it. So we don't go for any supplemental parenteral nutrition. So even in gastric patients who have a feeding jejunostomy, this is the way we prescribe. Anybody else who has a feeding tube and it's for after the first initial 48 hours, we would start feeding them. Maybe we'd go slowly, smaller volumes, and then gradually build it up, aiming for a 70% calorie target by the end of the week.
Okay. Is there anything specific from a pediatric point of view?
I think most of them are prescribed by the surgeons in terms of when the baby is ready. So if from a surgical point of view, the gut is ready and you have an appropriate tube, then the only concern would be if somebody is having very high lactates and on very high dose of inotropes. Other than that, in almost all scenarios, we would start them on feeds based on the surgeon's choice.
Okay. Ashwin, any disease-specific modifications like in neonates?
No, the calorie requirement would be the same. Again,
Okay.
surgical, one of the major problem that we see in neonates is actually the tracheoesophageal fistulas.
Okay.
Or major upper GI obstructions like diurnal atresia and all that. In these scenarios also, these babies would be on TPN because post-surgery, even if you have that the tube distal to the anastomosis, you still cannot feed because there is a risk of the feed reflexing back into the anastomotic area and then causing leak. So the surgeons are really worried about it. So most of the time what happens is 5 days the baby is actually kept NPO, or in the sense we don't feed enterally. So these babies really need a lot of TPN. Again, with the catabolic state because of surgery, they really need TPN.
Okay. Looks like there's a lot of questions there. Okay. Before that, Shamsa, one thing is that especially with COVID and all, we are proning a lot of patients. So when the patient is proned, how do you manage the nutrition?
So I mean, even before COVID, when we are proning, we would tend to stop them feeding enterally, but that's not the recommendation. The recommendation is to continue feeding even if they are on neuromuscular blockers, even if they're being proned and all that. Like Dr. Sajid mentioned, if they are significantly hemodynamically unstable on high-dose vasopressors, we would stop them. But proning as such is not a contraindication. You should assess for tolerability. What we tend to do now is to give 50% of the volume as otherwise we would give them, is what we tend to practice. But some of them do not tolerate that. We might give them a small breaks in between, but otherwise proning as such is not a contraindication for enteral feeding.
Okay. Now we'll move on to the audience question. I will start with a question to Ashwin from Shweta Singh. When to stop TPN in ICU, and is there any criteria set to stop TPN in preterm and term babies?
Obviously, once you reach 120 ml per kg of feeds, you don't need TPN anymore. 120 ml per kg would give somewhere close to 90 kilocalories per kg per day of nutrition. So beyond 120, you generally don't continue the TPN. That's applicable for preterm and term infants. Unless you are not winning in terms of weight gain, we just sometimes actually continue lipids or aminoven, that is protein, slightly longer. But other than that, once they are on 120, we stop.
Okay. That's a question like from Guraram Singh. Please tell brief details about TPN for adult critically ill patients. I think we have an entire talk on it, so kindly refer to the session. How do we wean off TPN in adult patients? Shamsa.
Okay, TPN is not prescribed in the first place, especially in the first 1 week or so, 5 to 7 days. So someone cannot meet even 70% of their calorie requirement enterally, or if they're totally contraindicated, only then you would go for TPN. But once you start feeding them enterally, a similar sort of approach, if you meet 50% or 50 to 70% of the caloric requirements can be met by the enteral feeding, then you could stop the parenteral. What we sometimes tend to do in patients with, say, acute pancreatitis is to give them only partial parenteral nutrition. We don't go on to a total parenteral nutrition. The advantage being you can use a peripherally insert a central catheter rather than have a proper central catheter. You could give through that. And we don't give the total calories through that. And once the enteral feeding calories percentage increases to 70%, definitely you can stop the TPN.
Okay, fair enough. Ashwin, again another question to you from Naveen Nehra. Can hypomagnesemia cause seizures in preterm neonates?
Hypo, definitely yes. Hypomagnesemia actually it plays a major role in calcium metabolism. Actually, it inhibits the PTH action for absorption of calcium. So basically, they develop hypocalcemia because of that, and then that can definitely cause seizures. Hypomagnesemia, yeah. So basically, that's the main reason. So generally, when you have a baby with seizures, if you find the calcium is low, immediately what we do is actually check a magnesium levels, and then make sure that you give supplement magnesium. This is something which we commonly see in babies who are on diuretics, especially Lasix. They lose a lot of magnesium, and then we only focus on the calcium, and then sometimes we find that the magnesium is really low. So that really needs to be supplemented in the TPM also. So we add magnesium.
Right. I'm skipping few questions because we have already answered it, or it is not very much relevant to the current topic. There is Rubisco talks. So, role of TPN after bariatric surgery. You want to take the question, sir?
Oh, absolutely not. There's no role for TPN after bariatric surgery. We start feeding them, I guess, the very next day or within 48 hours, they start feeding them. So I don't think there's any role for TPN at all.
Okay. Ashwin, I think a lot of questions are to you. Any association between TPN and NEC in preterm? What is NEC, by the way?
Necrotizing enterocolitis again is a major disastrous complication we see in preterm in infants. Actually, it causes acute significant inflammation of the gut.
Okay.
So we see that generally in extreme preterm babies, especially when they are on feeds, and most likely when they are on formula feeds. Breast feeds actually has slightly more advantage than formula feeds in the incidence of actually NEC. So when a baby has NEC, those babies are most likely NPO for at least 14 days. So these babies actually are on TPN.
Okay.
So NEC, TPN causing NEC is not heard of. Actually, when they have NEC, most of them are on TPN because we cannot give any other nutrition. But most babies, we start small amount of feeds called minimal enteral nutrition. That is very essential to keep the gut moving. Again, like what Sir mentioned about bacterial translocation, these things actually prevent NEC. So NEC TPN leading to NEC is something that I have not heard of.
Okay. So I'll put the next question to you from again Shweta Singh. What are the things to monitor when children are on TPN?
So you have to monitor their glucose levels, because when you give a very high GIR or very high percentage of glucose, they can develop hyperglycemia. Second is you need to monitor their electrolytes, including sodium, potassium, magnesium, phosphate. And then you have to do triglyceride levels to check whether their fat they're tolerating. So this would be the main things that and then you do once a week LFT. You do renal functions also on a weekly basis. This is what you.
Okay. Sham sir, again, I think a lot of interest in TPN. Can you give TPN through peripheral veins?
Yeah, there are some formulations which you can give. So you can't give every formulation through a peripheral vein. There are some formulations which is called as partial parent or peripheral, which you can give through a peripheral line, but that is also through preferably a PICC line or some large cannula through a large vein. But you'll need to check with the manufacturer if that can be given. Only then you can give.
Neonates actually we give TPN through a peripheral line.
Okay.
But again, we make sure that the dextrose concentration is not more than 12.5%.
Oh, okay. I mean, a few more questions to Ashwin, but it does not fit into the current discussion. Probably we'll have Ashwin another day for a Q&A session. Okay, hypokalemia patient and chronic renal patient, what should be the nutritional requirement in adult patient? Yeah.
Sorry?
What is the nutritional requirement in chronic renal failure patients? And probably I'll restrict to that.
Yeah, I mean, calories, there's no difference. I think they're asking about protein. There is, as such, if they're having a critical illness, there is no restriction of proteins as well in them. Potassium, you'll have to monitor. I mean, there's the same amount of potassium requirement they do have. But if they're having hyperkalemia, resistant hyperkalemia, of course, you'll have to restrict. Otherwise, as such, requirement-wise, there's no difference in renal failure and otherwise. So proteins also, you're going to give them normally. If your renal failure patient is especially on dialysis, which many of them are in the ICU, then there's no need to restrict any protein or anything. Of course, you'll monitor the electrolytes as frequently as it is required.
Okay. I think we have, there are a few more questions, but we have reached 4 p.m. here. So I will stop the discussion here and with the closing comments from everyone, and I'll start off with Ashwin.
Yeah, like we discussed, nutrition again is very important. Now we have realized that it's different in pediatrics and in an adult compared to neonates. Again, any small chance of increasing the calorie protein in an ICU setting, we must really jump on it and then try and give that nutrition. Sometimes we get focused on the disease process and then ignore the nutritional aspect of the baby. So what we generally do to avoid this is actually have a nutritional rounds. So our fellows and our team actually talk about just the nutrition of the baby as when they write the daily summary of the baby in the NICU. They talk about the feeds, electrolytes, fluids, electrolytes, and nutrition. We call it FEN. So in that nutrition, we really calculate how much calorie and protein the baby is actually getting.
Okay.
So if there is a deficit in the protein and calorie, we see ways to increase that. So that actually really helps in our babies actually to achieve that target or the goal of nutrition. Actually, that again is a quality improvement program. Okay, if you really can, each NICU can actually look at just the nutritional aspect in addition to the disease process which the baby is having. That actually can reduce the extrauterine growth restriction which I was talking about.
True. Dr. Sajid?
One thing I wanted to comment is people might be confused about this different approach to neonates, children and adults. And I have to assure people that this is not because different people are involved. It's more because of their physiology. Like the growth is maximum in neonates. They gain 30 grams per day. Or so if on a daily basis, if they don't gain weight, the neonatologist will get worried. Whereas in children, they have growth, but they also have some adult physiology. So again, there is a balance between this extreme and that extreme. And in adults, it's not about growth. They have finished their growth. It's mainly about losing muscle mass and other things. So that's probably the main. And also their metabolism response, all of that would be different. So please don't think that this is because we practice in different units. It's mainly because of the physiological changes.
Sure, thank you.
So just to summarize on the adult, the main highlights would be anyone who's going to stay in ICU for more than 48 hours is at risk for malnutrition. So nutrition has to be taken as part of therapy of critical illness and not as something additional. And weight alone is not a good indicator of nutritional status. Overweight people can be malnourished. And enteral feedings is the mantra. Early enteral feeding, that is what is preferred. Parental nutrition can be used as a supplemental form if required.
Okay. Thank you, Shyam sir, Dr. Sajid and Dr. Ashwin. And also a special thanks to all our viewers who had listened to this session and shared your questions. I know that we couldn't take all your questions, but definitely I think we will have more sessions in similar lines as we move on. And also do join us for tomorrow's session. Again, at the same time at 2 p.m. we will be starting off. Tomorrow we'll be dealing with rheumatological emergencies. Again, the format is same, 2 sessions, 2 talks, followed by a panel discussion. So see you tomorrow. Have a good day. Thank you.
Thank you for having us.
Yeah.